Hi, my name's Sandeep, and I'll be presenting how to review a patient with deranged blood sugars. So you're the doctor on call, and you've been asked to see a patient who has a deranged blood sugar. What are the questions that you should ask the nursing staff who have referred the patient? Well, the first question you should ask is, how high or low is the blood sugar? And particularly, has this been the case throughout the day, or is this new? Is the patient known to be diabetic? Perhaps they're on insulin? What have they been like throughout the day? Have they been eating and drinking? Have they been kept not by mouth? One of the most important things to ask is whether they're symptomatic. Does the patient have any nausea or vomiting? Are they confused or complaining of any pain? And when was the reading taken? Is this a pre-meal reading or a post-meal reading? One of the things that you need to then ask the nursing staff to do is a set of observations, including the saturations and the temperature. The next most important thing is that they treat the patient immediately if the blood sugars are less than 4 millimoles per litre. So let's move on to an A to E assessment of a patient who has deranged blood sugars. So the first A, airway. It's important to assess the airway and whether it's patent, because that will determine whether the patient can have oral medications, for example, for a hypoglycemic episode, or whether they need IM or IV medication. So if they're unable to maintain their own airway, they might require IM glucagon or IV dextrose if their blood sugar is less than 4. Moving on to B, breathing. When examining the patient, listen out for crackles. One of the common causes for precipitating DKA can be sepsis or infection, and lower respiratory tract infections are quite common. This is a good example here of a patient with a lobar pneumonia. Crackles can also be auscultated within heart failure, as can wheeze. And heart failure is particularly important in DKA because it's a known complication both of DKA and of the medication used to treat DKA, IV fluids. If a patient has a wheeze, keep in mind that they might also have a diagnosis of COPD. And if a patient's recently had an exacerbation of COPD, they may well be on steroids, and that might be leading to a high blood sugar. Does the patient have reduced air entry? Again, this might be in keeping with heart failure and pleural effusion. And lastly, does the patient have a pear drop smell to their breath? This is the typical textbook description of patients with DKA. Moving on to C, circulation. There's lots of signs that you might be able to elicit with a patient who's got a high blood sugar. So we talked about a raised JVP. We talked about heart failure. And one of the things you can see is a raised JVP after the treatment, perhaps, or as a result of DKA. But most commonly, the presentation for DKA in terms of circulation is usually that of dehydration and hypotension. And usually with this comes dry mucous membranes, a thready pulse, hypotension, and generally shock. Hypotension within DKA is a red flag, and it's very important to get a senior review. Listen out for a murmur. The patient might have had an underlying myocardial infarction which has precipitated the DKA, or perhaps this is a new murmur and this is infective endocarditis that's causing it. Check the peripheries. Again, the most important thing here we're looking for is the patient in shock? For a patient that's had a hypoglycemic attack, they usually present with pallor and clamminess. Moving on to D, disability. It's important not to base your judgment on one glucose reading, and it's important to, as a result, get serial glucose readings throughout the day. Assessing patients' responsiveness is then the next most important step. A general score through AVPU. If the patient's unresponsive, then this would mean that you would treat with an IV or IM mode of medication. But also, if the patient's got a reduced GCS, you need to consider contacting ITU, because patients with DK or deranged blood sugars and reduced GCS, i.e. high blood sugars with reduced GCS, you need to consider that they need to be moved to ITU. E, exposure, everything else. So there's lots of things that come under E, but we'll talk about some of the most important to look out for on examination for a high blood sugar first. So temperature, could this be sepsis or some sort of underlying infection precipitating deranged, highly deranged blood sugars that are high? Is there any evidence of a surgical scar? So post-operatively, stress can cause DKA. Does the patient have any tenderness? So patients can have abdominal tenderness with abdominal pain within DKA. Is there any evidence of subcut injections? So is the patient already on insulin perhaps? Or on another subcut hypoglycemic agent? Does the patient have any signs of acute or chronic liver disease? Perhaps this has decompensated and as a result potentially precipitated DKA or just deranged blood sugars in general. Then look at the skin. So look for cellulitis. It's important in patients that are known diabetics to check the perineum, particularly because Fournier's gangrene is common both within diabetics and those diabetics that are on gliflozins like dapagliflozin. Next, we'll move on and talk about the signs that you might see in a patient with low blood sugars. So one thing to look out for are hyperpigmentation of the palmar creases. So we're thinking of Addisonian crises. So this is a good example of a patient who's got quite hyperpigmented palmar creases. Look out for vitiligo. So the patient might have signs of other autoimmune diseases, which makes Addison's or Addisonian crisis more likely. If a patient's having a hypoglycemic episode currently, then they might have a tremor. They might also have other focal neurology, including slurred speech. So let's talk about the sort of things that we ought to ask the patient during our history. Well, the most important question is to work out whether the patient's already known to be diabetic. Particularly if they are diabetic, then are they on insulin or do they take any oral antiglycemics to control their blood sugars? Another important question in terms of the history, the past medical history, is to find out if they have any other autoimmune disease. Because like I said before, it's more likely that they'll be diagnosed with other autoimmune diseases like Addison's if they're already known to be diabetic or have problems with their thyroid. So for patients presenting with a high blood sugar, questions that we need to ask them are, has the patient eaten or drank in the last 24 hours? And has this been the normal amount that they eat and drink with the amount of insulin they inject, for example? Has the patient had any vomiting? Have they had any nausea? Have they had a reduced appetite? Has the patient had any abdominal pain? And then next, ask them about their drug history. So if you've worked out whether they're on insulin or antiglycemics or oral, but what about things like steroids? Recent prescription of steroids or recent tacrolimus will both cause the blood sugars to creep up. If the patient's malnutrition, then ask them whether they take any Fortisip-like supplements. So if a patient has a low BMI and they're diabetic, then it's important to consult the dietitians and for the patient to have an appropriate nutritional replacement according to their blood sugars. If a patient has low blood sugars, then we need to work out whether they were symptomatic during the last episode or whether they didn't notice. So, did they have any symptoms? Were they sweaty? Were they clammy? Were they tired? Were they feeling faint? But also, when did they last eat? Has the patient had previous hypos? Have they needed help with their previous hypoglycemic episodes? And again, are they taking any medication? Perhaps they're on insulin. Perhaps they're on some oral agents. Or perhaps perhaps they're on regular steroids that have been stopped recently, and as a result, they've gone into an Addisonian crisis. It's important also to work out if the patient has an erratic lifestyle. For example, in patients with high blood sugars, DKA is obviously the worry, and patients who've got an erratic lifestyle, or students, patients with busy lifestyles, and alcoholics who tend not to eat very much, are all sort of high risk patients with who are at risk of developing DKA. Next, let's talk about the investigations. So your patient's got a high blood sugar or a low blood sugar. What should you order in terms of the blood tests? Well, most commonly, you want to do a routine set of bloods. So FBC, CRP, this is to look for signs of infection, necrotizing fasciitis or cellulitis, perhaps lower respiratory tract infection. You want to look out for a raised white cell and a raised CRP. Next, you might want to check the TFTs if there's any indication that they may have other autoimmune diseases, including thyroid problems. LFTs and USNEs will give you an indication about whether the kidneys or the liver have decompensated to cause this derangement. And troponin if they've complained of chest pain, which can be an underlying cause of DKA. If the patient's got low blood sugars, it's important to consider checking their cortisol, particularly at 9 a.m. And if it warrants it, then doing a short synactin test, well, I'll talk about a little later. If you're concerned that the patient's quite well with a low blood sugar, then relying on the capillary blood gas is not always appropriate. And doing a venous blood glucose, which should be present on the blood gas, is a good way of checking that the blood sugar is actually low. If when you review the patient, you think that the patient might have had an insulin overdose, or that they might have an insulinoma, you're trying to differentiate between the two, then you can always order a C-peptide and a pro-insulin. If there are any signs of infection, or the patient has any symptoms that might suggest that they've got sepsis, then a blood culture would be appropriate at this point. Moving on, blood gases. It's important to get a venous blood gas, particularly patients who are unwell with a high blood sugar, because you're looking for diabetic ketoacidosis. The blood sugar will show you the blood gas will show you the venous blood sugar, which is obviously more accurate than capillary, but also it will tell you whether the patient is actually acidotic, i.e. with a low pH or a high bicarb, whether they've got any ketones in their blood, and also whether the lactate's high. And this could be indicative of many causes that might precipitate DKA. Urine, aside from checking from infection and checking that the glucose is also present within the urine, the most important thing that you can do on the urine dipstick is check for ketones. And we're looking for 3+ ketones here. Often wards don't stock a blood ketone meter, so it's the quickest way to check a patient's ketones. If the patient has symptoms or signs of a chest infection or heart failure, it'd be important to get a chest X-ray to check for consolidation or collapse, perhaps pulmonary edema. And then there are some indications for why you might do an ultrasound or a CT of the abdomen. So if they have, for example, a surgical emergency or a surgical abdomen, that can precipitate DKA. So that might be one of the indications to do one more immediately. But perhaps later down the line, if the patient's found to be Addisonian, then they may well have an underlying adrenal tumor or adrenal hemorrhage. And this is a good example of a patient who has had a CT scan, and here there is a right-sided adrenal tumor. Sometimes patients can present with Addison's that's not a primary Addison's, i.e. it's not an adrenal problem, but it's a secondary Addison's, and that's usually with the pituitary. And a CT head or an MRI head may be warranted at a later stage to investigate a patient with Addison's crisis, and they might show a pituitary tumor. Sometimes patients can have deranged blood sugars and they are not in DKA. If this is the case, then We'll just briefly talk about why that might be. Well, usually it's because the oral intake is reduced or the output is increased. So for example, a patient might be nil by mouth before an operation, or they might have increased vomiting or diarrhea. And as a result, their normal insulin dose that they take is either too much or too little. The patient can also be acutely unwell. So perhaps they've got a concomitant infection or they've had a myocardial infarction, and as a result, their body's not processing the insulin as it normally would do. We spoke about preoperatively, there might be nil by mouth, but also postoperatively patients can have derangement. If the patient suffers from any mental health disorders or has an increased alcohol intake, then their use of insulin may be erratic, and as a result, they may not have stable readings even at home. It's important to get the diabetes specialist nurses involved as soon as possible so that they can come up with a long-term plan for these patients. If you have a patient who's got high blood sugars and they're well with the high blood sugars, they're not vomiting, don't have any signs of DKA, then the first thing to do would be to check the time that the patient had the high blood sugar. So look at the trend. Is this something that happens before breakfast every morning, or is this just a one-off? If it's something that's happening regularly before breakfast, then it will be appropriate to change the nighttime insulin dose so that the blood sugars aren't high or low. And if it was a high blood sugar in this case, then you would increase the insulin the night before by 10%. If the patient's suffering from low blood sugars, perhaps the before breakfast reading is very low, then you need to decrease the insulin by 10%. It's important to make sure that there is a trend before you do this, and it's not just based on a one-off reading. I mentioned earlier that it's important to ask whether the patient had the blood sugar reading checked pre-meal or post-meal. And the reason for that is that post-meal, we expect their blood sugars to be higher. So if a patient's suffering from a low blood sugar post-meal, that's quite worrying, but any readings that are taken routinely should be done pre-meal only, and you can ignore the post-meal readings if they're high. If the blood sugars pre-meal are reading above 18, then check your local trust policy. Some trusts prefer ActRapid and some NovoRapid, but the general consensus is to give a short-acting insulin between 4 to 6 units if the patient's presenting with a high blood sugar. So let's briefly talk about DKA. So DKA, essentially, the underlying process is that there's no insulin in the body either because of type 1 diabetes where the pancreas doesn't produce any, or type 2 diabetes where the pancreas is resistant to the insulin. As a result, there's lots of sugar in the blood. The liver then produces more sugar and this accumulates. The body then breaks down fat into ketones, which are acidic, mild acids, and because the fat breakdown has produced this, the kidneys then need to get rid of both the sugar and the ketones. Getting rid of the sugar and the ketones takes lots of water, and that's how patients end up in dehydration. So the first thing to do with a patient who's got diabetic ketoacidosis is to confirm the diagnosis. So the first thing would be to check for ketones. You can do this one of two ways, either checking the blood ketones via a bedside ketone meter or on the blood gas. These ketones should be more than 3 millimoles per litre, or by doing a urine dipstick for ketones. There should be more than 2+ ketones, so 3+ ketones either on the dip or more than 3 on the blood ketones. Next, blood sugar. If a patient's known to be diabetic, the blood sugar can be normal, so don't be swayed by a normal blood sugar if you're thinking the patient might have DKA. If in a patient who's not known to be diabetic, DKA can sometimes be the first presentation of an unwell diabetic patient, and the blood glucose is usually more than 11 in that case. Thirdly, the pH. or the bicarbonate. So the pH has to be less than either 7.3 or the bicarbonate has to be less than 15. Next, it's important to check the A to E assessment. So go through A to E and treat the patient. If their saturations are low, they will need oxygen, and if their blood pressure is low, then they will need a bolus of fluids. At this point, it will be important to get access, if you haven't already got some, and to send a routine set of bloods, which we discussed earlier, to check for signs of infection, perhaps to check for rise in troponin if they may have had a myocardial infarction. The next step is to give 10 units usually of subcut insulin. It's important to check your local policy, but this is an example of a DKA guideline from a trust in the East Midlands. And then the patients need fluids. So if the patient's blood pressure is less than 90/60, then it's important to give a bolus in order to bring up the blood pressure. But if the blood pressure is normal, then the fluids that are given with the fixed rate insulin are usually enough. It's important to keep reviewing the patient's fluid status because there is a chance that they may go into heart failure because of the level of fluid that's being pumped through. Next is a fixed rate insulin. So there should be a chart that accompanies a guideline, and that will talk you through, or talk the nursing staff through the dose and how to give it. Usually it started with saline if the blood sugars are above about 15, but it's then switched to dexsaline if the blood sugars drop below that level. It's important during this to replace the potassium, and different trusts have different guidance about how much potassium to give, usually between 20 and 40 millimoles. If the potassium every 2 hours is checked, then it's between 3.5 and 5.5. If it's any less than that, you normally need to get a pharmacist and your senior involved. And if it's any more than that, then it's usually just not given with the next bag of fluids. You've got to remember that insulin is a treatment for hyperkalemia, so it does bring the potassium levels down. Patients that have DKA are more likely to clot, so making sure they're on VTE prophylaxis is next concern, and then eventually determining the underlying cause of why they've gone into DKA. Now let's talk about Addison. So patients that have got low blood sugars might have an underlying diagnosis of Addison's, and it's important to check, for example, their sodium and their potassium levels because they might present with a low sodium and high potassium. So Addison's is all to do with the cortisol levels. I'll briefly talk you through the HB axis over here. So we have the hypothalamus that produces the corticotropin releasing hormone. This acts on the anterior pituitary, which produces the adrenocorticotropic hormone. And then this acts on the adrenal gland, which produces cortisol. The cortisol then acts as a negative feedback on both the hypothalamus and the anterior pituitary. Within patients who've got Addison's disease or underlying Addisonian disease, they usually have an acute illness that precipitates the symptoms. This can be an infection, for example. It might be trauma. It might be a myocardial infarction, or the patient might be on regular steroids and these have been stopped. The patient will usually have an underlying problem with either the adrenal glands, which is known as a primary Addison's disease, or with the pituitary, which is a secondary Addison's disease. Primary Addison's disease usually is because of a hemorrhage if they're on anticoagulation, or it might be to do with metastases within the adrenal glands, or just a tumor. The tumor might be a solid tumor, lymphoma, or in some patients who've had bilateral adrenalectomy, you might see the patient have primary Addison's disease. If it's a secondary Addison's disease, then it's usually an anterior pituitary tumor. So going about diagnosing Addison's disease, you want to check a 9 a.m. cortisol level. And this is usually a reading of like less than 200 will be confirmation of the diagnosis. Or if it's any higher than that, you might need a short synactin test. Essentially, in order to do this, the patient has their cortisol level checked at 9 in the morning. The synactin is given, usually 250 micrograms, and then half an hour later, the cortisol levels are rechecked. When you're doing cortisol levels with or without synactin, it's also a good idea to check the ACTH at the same time. And the reason we check the ACTH is to determine whether the patient has primary or secondary Addison's disease. In primary Addison's disease, we'd see that the ACTH was high because there was no negative feedback. In secondary Addison's disease, the ACTH can be normal or low. The treatment for Addison's is essentially, after diagnosis, 100 milligrams hydrocortisone, IV or IM, QDS. Because the dose is so high, you don't need a mineralocorticoid at this point. After 24 hours, this is dropped down to oral, 20 milligrams TDS, which is then weaned to 10 milligrams TDS. Patients usually go home on a maintenance dose of 10-5-5. If the patient's then found to have primary Addison's disease because the ACTH is perhaps high, or we found a cause within the adrenal glands, then it will be appropriate to add fludrocortisone at this point. The dose is usually between 50 and 200 milligrams, depending on the weight of the patient. If you're treating patients acutely, it's important to give them IV fluids to keep their blood pressure up because they often drop their blood pressure and they feel very unwell. Sometimes they require 4 to 6 hourly bags. And of course, treating the underlying cause is really important. A lot of patients present with infection, and so putting them on antibiotics is something that often helps their symptoms. Thank you for listening to this talk. Please fill out the feedback by the link below. See you next time.